All right, so today we continue with mediastinum and boundaries of the middle mediastinum. As I've said, I like to use the Felsen scheme when we're dealing with the chest radiograph. So the first line anterior to the trachea coming down behind the heart, the second line 1 centimeter posterior to the anterior border of the vertebral bodies. So everything in here becomes middle mediastinum, and then behind the second line becomes the posterior mediastinum. So when we look at this chest radiograph, which mediastinal line is deviated by the mass?
The azigoesophageal.
Yeah, so this is the azigoesophageal line, so here is the mass, right? So then that tells you that, so this mass is located where then?
In the middle mediastinum.
Middle mediastinum, right, because the esophagus in this scheme counts as middle mediastinum. And it's also in this subcarinal location, right? So if you have a round subcarinal mass, what's the first thing you consider?
Bronchogenic cyst.
Bronchogenic cyst, right? So on the frontal view, there it is there. On the lateral view, hard to see, but it's down here. And then the CT looks like this. So is this a bronchogenic cyst?
It has some enhancement, so.
Yeah, so the lesion is enhancing. So this is non-contrast, post-contrast. If there is enhancement in the lesion, then we can't call it a bronchogenic cyst. So even though it's in the right location, we have to think of some other things. So what's your differential for an enhancing mass in this location? What would it be? Any ideas? No ideas? I mean, this turned out to be lymphadenopathy. Subcarinal lymphadenopathy could be from metastatic disease, lymphoma, infection. In this case, it was tuberculosis was the cause in this case. Other things that you might consider, you could have a mass related to the esophagus, right? What kind of mass related to the esophagus might give you a lesion that looks like this? Well, the first thing you think of is carcinoma, but that usually gives you circumferential thickening of the esophagus. This looks like it, if it is from the esophagus, it's growing away from the esophagus. And what kind of tumors do that? So that would be a gist tumor of the esophagus. But this was enhancing. This turned out to be lymphadenopathy. Another example, subcarinal round mass. There it is on the lateral view. You can see a nice donut sign, right? Okay, somebody needs to be muted out there. Okay. So here, it is higher in attenuation than simple fluid, but we can't see this with bronchogenic cyst. The important thing is there any enhancement? So it's pre-contrast, post-contrast. It is higher in attenuation than simple fluid, but this does not demonstrate enhancement, okay? So this does turn out to be a bronchogenic cyst. We've covered these before, so I won't go through this in any great detail about what you need to know about these bronchogenic cysts. Turns out they can occur in all mediastinal compartments, although they're most common in the middle mediastinum, and they might enlarge due to hemorrhage or infection. So usually it's a round subcarinal mass that's well marginated. On CT, it may be fluid attenuation, or as in this case, can be higher than fluid attenuation, but it should have very smooth walls. There should be no enhancement. So that's what we see with bronchogenic cysts. Other things you might see with these, calcification in the wall, milk of calcium, that can also occur in a bronchogenic cyst. On MRI, they can be higher than fluid signal on T1 because of proteinaceous contents, but they would be very bright on T2 weighted imaging. And post-GAD, there will be no enhancement in these lesions. So that's what we see with bronchogenic cysts. This lesion here measures low attenuation on the non-contrast CT. Then I have a post-contrast CT. Is this a solid mass or a cyst?
Solid mass.
Everybody agree?
you want to be careful because the attenuation of the vessel nearby might be affecting
So what should you do?
weight a little bit, like a minute.
Yeah, so I would always advise getting a slightly delayed image also. So a few reasons for that. Sometimes even solid lesions might enhance a little bit later, okay? But as in this case, when you have dense contrast in the vessels in the mediastinum, that can throw off your measurements for the attenuation values of these things. So with CT, if we're doing pre and post contrast CT for mediastinal lesions, we're looking for enhancement, usually trying to differentiate solid lesions from cystic lesions. And so there it's important after your initial phase, I would recommend that you also get delayed imaging through the mass just to make sure that any changes in attenuation aren't artifactual from dense contrast in the surrounding vessels. Okay? And so this indeed was a cyst. This went on for MRI, very bright on T2. You can see bright on T2 and then no enhancement after giving gadolinium. So that does confirm to be a cyst. All right. What about this lesion? We can see it here on the radiograph, and we have a CT, and we have a T2 weighted MRI. What do we think of this? Well, what do we notice on T2MR? It is very bright, right? So do we think that's a cyst?
Yes, it can be.
Okay, so what kind of cyst would this be?
Esophageal duplication cyst.
Well, it's in that same kind of spectrum of abnormalities, but you can be a little bit more specific with this one. What would you say? What's this guy over here? That's the esophagus. So when you have a cystic lesion like that in the mediastinum that's in contact with the esophagus, what are we going to call it? That's an esophageal duplication cyst. All right. So same along that spectrum of bronchopulmonary foregut malformations, these tend to occur lower in the mediastinum, and these are in contact with the esophagus. So a lesion like that can also occur in the middle mediastinum. Cystic lesion in contact with the esophagus, so that's an esophageal duplication cyst. Kind of very similar to bronchogenic cyst as far as the imaging characteristics of that. This is an even larger one. This looks like a large mass there, and this turns out to be another esophageal duplication cyst, although that one is pretty large. Okay. What about this case? What's going on here?
On the lateral, I see deviation of the trachea.
Yeah, so there's deviation of the trachea, so the mass is behind the trachea. What lives behind the trachea?
Esophagus.
The esophagus, okay. Is there any other interesting finding on the lateral view? You can see there's deviation of the trachea even on the frontal view, but any other interesting finding on the lateral view?
One thing, distal esophagus has diarrhea, or
Well, that's just a mirror down there, I mean, between the heart and the vertebral body. What do you notice about the trachea on the lateral view?
there appears to be like a indentation.
Yeah.
In the wall.
So, what do you think that represents?
I would be suspicious for maybe a mass. In the trachea.
So, mass invading the trachea. So, what do you think this is then?
Could be a broken down esophageal tumor,
Like?
like
Yeah. So, esophageal cancer, right? So these lesions are usually present with obstructive symptoms before you can actually see them on chest radiograph. But on imaging, on CT, you get circumferential thickening of the esophagus. The esophagus, remember, lives behind the trachea, so large masses can deviate the trachea anteriorly. So that's an example of esophageal carcinoma in this case. All right, so that can give you thickening of the tracheoesophageal stripe, can cause obstruction of the esophagus. Although it's unusual to make the diagnosis on chest radiograph, as these are usually present symptomatically before they get large enough to be seen on a chest radiograph. But the typical appearance on imaging is that circumferential thickening of the esophageal wall. Might also have adenopathy and other findings associated with esophageal cancer. All right. What about this? What's kind of different about this mass?
There's some calcifications in it. It's mostly around the esophagus. It's not like circumferentially causing narrowing.
Right, so this one is not causing circumferential thickening of the esophagus. It is in contact with the esophageal wall. You can see that, and it has calcifications in it. So for this lesion, what might we consider?
Esophageal gist tumor.
Yeah, this is an esophageal gist tumor, right? It used to be called leiomyomas or leiomyosarcomas. So these are esophageal gist tumors. These arise within the wall of the esophagus, can be inseparable from the esophagus. These tend to grow away from the esophagus as opposed to esophageal cancers that cause obstructive symptoms of the esophagus. All right, so those are gist tumors. Here's a very large one. You can see it's a large tumor not causing much obstruction of the esophagus in this case. So these tumors can also originate from the esophagus. All right, here's another interesting frontal and lateral chest radiograph. What are the findings here?
Looks like there's like a smooth widening of the mediastinum.
Okay, so we have widening of the mediastinum, yeah. You can see that.
Going down below the diaphragm.
So there's some opacity here that extends down below the diaphragm. Do you see it on the lateral view? Well, what do you think of the trachea on the lateral view?
It's
Mass effect.
Yeah, so again, there's mass effect on the trachea. It's deviated anteriorly. So we've learned what lives behind the trachea?
the esophagus.
Esophagus, okay. So any thoughts about this case?
Could be achalasia.
So what's the finding that really gives it away?
Air fluid level.
Yeah, there's a nice air fluid level here. Okay, and you can see that on the lateral view too. So this is the right heart border. This is the distended esophagus. So with achalasia, the esophagus distends towards the right, and you can see it's extending down below the diaphragm in this case. The air fluid level really helps, okay? This can be very confusing on the frontal view, so you want to be able to recognize it. So a mass behind the trachea that extends all the way down. Think of a dilated esophagus from achalasia. So there's your dilated esophagus, dilated all the way down to the gastroesophageal junction. There's debris and fluid there within the dilated esophagus, the typical appearance of achalasia with the beak sign on the barium study. Right? So we're pretty familiar with achalasia, but it can be very confusing on the frontal view, so you want to be able to recognize that when we see that on the frontal view. So sometimes it's, like I said, it's confusing on the frontal, but on the lateral, if you notice the deviation of the trachea, the fact that it's extending all the way down, and of course the air fluid level, very characteristic finding. Other things that can give you masses in the middle mediastinum lymphadenopathy. There are many causes for lymphadenopathy, like metastatic disease. So these are some tumors that can metastasize to mediastinal lymph nodes, especially renal cancer that can metastasize to mediastinal and hilar nodes. Here's an example of a renal cancer here, metastatic disease to the bone. All this lymphadenopathy here was metastatic disease from the renal cancer. So renal cancers have a propensity to metastasize to mediastinal nodes. Other causes of lymphadenopathy, of course, there's sarcoid. That tends to give you bilateral symmetric hilar lymphadenopathy, also paratracheal, as in this case. Infections, TB, fungal infections. With TB, you can get low attenuation within the nodes. That can be a characteristic finding. So low attenuation lymph nodes, we can see that with tuberculosis, another cause of mediastinal adenopathy. And then, can we send a message to? And then we have, in this case, eggshell calcifications of lymph nodes, a characteristic appearance that can be associated with silicosis. Okay? Although there are other causes also of eggshell calcifications of lymph nodes. Rare cause of lymphadenopathy, drug reactions. Here are some drugs that can cause mediastinal lymphadenopathy. Here's a nice chest radiograph that shows a widened mediastinum. So it tends to be a non-specific finding. Your first thought, if we see this, might be what? Well, lymphadenopathy might be the first thing that you think about if you see a widened mediastinum. Okay. Here's the CT on this case. So what are some of the findings here on the CT?
There is pretty diffuse soft tissue like throughout the entire mediastinum.
Yeah, so there's soft tissue throughout the mediastinum. And we could see that it's encasing the blood vessels here, the great vessels, also the aorta. See the pulmonary arteries here are stretched. What is this guy over here?
Azicus?
No. That's this guy. Same guy, right. That's the SVC. And what's happening here?
Stenosis of the pulmonary vein,
Which one?
the left superior.
That's the left inferior. Yeah, the inferior pulmonary veins come in from the back. The superior pulmonary veins come in more anteriorly. So there's narrowing from encasement also of the left inferior pulmonary vein. So what might this represent?
Could be like fibrosing mediastinum.
Yeah, in terms of the differential though, what neoplasm would you consider?
Lymphoma.
Lymphoma, yeah. And that's usually why these patients need to go to biopsy. You want to differentiate lymphoma from fibrosing mediastinitis. What's the most common cause of fibrosing mediastinitis?
Histoplasmosis.
Histoplasmosis. Is this from histoplasmosis? Well, what do we look for to think of fibrosing mediastinitis from histoplasmosis? We look for what? In addition to the encasing, infiltrating mass in the mediastinum, we also look for what? Calcifications. Calcifications. With fibrosing mediastinitis, it's associated with calcifications. So if we think this is fibrosing mediastinitis and there are no calcifications, then this would be the idiopathic form of fibrosing mediastinitis. So fibrosing mediastinitis can also give you an infiltrative process in the mediastinum. So causes histoplasmosis, TB, sarcoid. This is the most common, but there we look for calcifications. So there's idiopathic causes, also drugs can be associated with other autoimmune diseases, sometimes X-ray therapy, IgG4 disease, so that can also give you fibrosing mediastinitis, although that's also associated with retroperitoneal fibrosis and some other issues as outlined there. So the fibrosis can cause obstruction of the superior vena cava, airways, pulmonary veins, pulmonary artery. From obstruction of pulmonary veins, you can get asymmetric pulmonary edema if one side is affected more severely than the other side. Chest radiograph, nonspecific finding, just widening of the mediastinum. On CT, we can have this infiltrative appearance of this mediastinal mass. In this case, there's some calcification here, so this one was from histoplasmosis. There's narrowing of the right pulmonary artery. Here you can see narrowing of the pulmonary arteries from the fibrosing mediastinitis in that case. Another example from histoplasmosis is there's narrowing of superior vena cava. The azygous vein here you can see has got dense contrast in it as it's trying to act as a collateral. And in this case, there's this ground glass opacity in the right lung. So what's causing that? Ground glass opacity in the right lung with right pleural effusion in this patient. Why is that happening?
Pulmonary venous.
Yeah, pulmonary venous obstruction right on the right side. So this is asymmetric pulmonary edema. And you can see that also with fibrosing mediastinitis. So the non-granulomatous form, more diffuse, we don't see calcifications. It infiltrates the mediastinum, causing narrowing of vessels. The differential is lymphoma, so this will require biopsy to differentiate that from lymphoma. And these are the associations for non-granulomatous fibrosing mediastinitis. Pre-contrast on the top, post-contrast on the bottom. What do we see? Well, he's got these nice round things in the mediastinum. What do you think these are? Lymph nodes, right? You also have this mass over here, which you might presume to represent lymphadenopathy. What happens before and after contrast?
If any, maybe mild enhancement.
It's a little bit more than mild. I mean, it is enhancing here. Okay, so we have lymphadenopathy that's enhancing there in the mediastinum, and of course lymphomas in your differential. What metastatic tumors are associated with vascular lymph nodes? Renal cell, thyroid, islet cell tumors, carcinoid, Kaposi's, right? But there's another cause of enhancing lymph nodes that you also need to think about. What is that called? Castleman's disease, yeah. So Castleman's disease, if we see enhancing lymph nodes, that can also be in the differential. There are two varieties, the hyaline vascular type, usually localized, more benign. The plasma cell type, this can be associated with HIV. Multicentric tends to be more malignant. So Castleman's disease can give you also lymphadenopathy within the mediastinum, and this is associated with marked enhancement. There's some calcifications there, but there's marked enhancement here after contrast. So we can see that with Castleman's disease. So the more malignant form, the plasma cell variety, is associated with Kaposi's, AIDS, and some other unusual diseases. This can also give you enhancing lymph nodes. So Castleman's disease belongs in our differential for enhancing nodes. Here's a patient with AIDS who has enhancing lymphadenopathy in the mediastinum and also in the axillary regions there. Okay. Now, as we move on to the posterior mediastinum, where is the mass and how do we know it's in the posterior mediastinum?
There's a cervicothoracic sign.
Yeah, so I have a nice cervical thoracic sign here. How do we know that's posterior?
Because it interfaces with air.
Yeah, it's interfacing with the air. You can see the lateral border above the clavicle, so that is a cervical thoracic sign. So posterior mediastinal mass, the first thing you consider is what?
Neurogenic tumor.
Neurogenic tumor, right. So it's bright on T2, there's peripheral enhancement, so neurofibromas, or neurogenic tumors. So what about this case? Another nice positive cervical thoracic sign, posterior mediastinal mass, there's the CT. What's going on here?
Doesn't appear to be actually enhanced. No.
Well, you have these masses all through the mediastinum, also here in the axilla, somewhat low in attenuation, and also here, and this is very characteristic, right? What does this patient have?
Neurofibromatosis.
Neurofibromatosis. You have all these are neurofibromas. You have bilateral paravertebral masses, and then these are also, you can also have neurofibromas anywhere with neurofibromatosis. These are in the mediastinum, plexiform neurofibromas there in the axilla. So nerve sheath tumors, posterior mediastinum, can be associated with neurofibromatosis. Schwannoma, neurofibroma, of course, the malignant variety is neurogenic sarcoma. So posterior mediastinal masses, nice cervicothoracic sign on that plain film. These can grow slowly, can cause scalloping of adjacent vertebra or ribs. So round masses can result in enlargement of neuroforamina there in the posterior mediastinum, and you might see enhancement of these lesions. A nice, there's a sign demonstrated on this chest radiograph. First of all, do we see where the mass is?
Looks like it's a posterior, we have a positive spine sign.
There is a positive spine sign. You see the mass on the frontal?
Yes, on the right cusp,
Yeah.
cardiophrenic border.
Yeah, here's the mass. So what sign is demonstrated here on the frontal chest radiograph? First of all, how can you tell from the frontal radiograph that it's a posterior mass?
Well, I can, yes, because I can still make out the cardiac border.
Yeah, you can see the heart border through the mass, so it's not in contact with the heart. This is analogous to the cervicothoracic sign, right? Above the clavicle, if it interfaces with air, it's posterior. Same thing is true when it projects below the diaphragm. If it's interfacing with air, right, that also implies that it's posterior and you have a spine sign. So what is the sign called?
Thoracoabdominal.
This is called the thoracoabdominal sign, right? You can see the lateral border well below the diaphragm, so it's interfacing with air, okay? So posterior mediastinal mass, here it is on CT, right? What can we say about it?
So there's internal fat and soft tissue.
Yeah, got some fat and soft tissue or low attenuation in soft tissue. Do you notice anything there on this view? What's the clue that it's a neurogenic tumor?
Oh, widening of the
There's
right
widening of the
neuroforamen.
neuroforamina, right? So this patient is, as we've said, a 9-year-old girl. Do we think that's a neurofibroma? What is it about this tumor that suggests it's not? And what neurogenic tumor would you think about here? So neurofibromas tend to be round. What about the shape of this tumor?
It's not round.
Not round. The long axis is parallel to the spine. So when we see tumors that do that, neurogenic tumors, what kind of tumors do we think of? So here's bright on T2. You can see it is extending into the neuroforamina, nice enhancement there. Okay, so you think of ganglion series of tumors, right? Sympathetic ganglion tumors. In very young children, you would think of neuroblastoma. In younger patients, or patients older than young children, ganglioneuroma. Okay, so these arise from ganglion cells. The long axis tends to be parallel to the spine as opposed to neurofibromas, which tend to be round. So in the very young age, you have neuroblastomas. Somewhat older here in the teenage years, you can have ganglioneuromas. In between, you can have ganglioneuroblastomas. But with the long axis parallel to the spine, you think of ganglion series of tumors. Right? So these also can give you posterior mediastinal masses, as we see there. Might have calcification. If I tell you this patient has this posterior mediastinal mass, there's marked enhancement, but I also tell you the patient has hypertension with elevated catecholamines. What do we think about here?
Extraadrenal pheochromocytoma.
Yeah, so paragangliomas, right? Again, these arise from ganglion cells, so that's a paraganglioma, right? So these can also occur in the posterior mediastinum. They can also occur around the aortic arch, aortic body tumors in the posterior mediastinum, in or around the heart, within the atrium. 1/3 are functionally active, so patients can't present with hypertension or will have elevated catecholamines. So you can recommend doing that. If you see a markedly enhancing tumor around the heart, you're thinking of paraganglioma, you can recommend that they get look at the catecholamine levels. Right? Some of these can be malignant. 50% of paravertebral paragangliomas produce excess catecholamines, and the I-131, MIBG, iodine MIBG, another way for looking for these to characterize these hormonally active lesions, right? But they are vascular, they tend to enhance quite a bit, these paragangliomas, okay? Again, the long axis can be parallel to the spine with these lesions, and with MIBG, that can show activity within these lesions also, so you can also recommend that study if you're considering this, the paraganglioma, okay? And these are areas where we can get neurogenic tumors in the mediastinum, also around the aorta, around the pulmonary artery there, around the heart, and the paravertebral regions. So here's a there's an infant here with a large posterior mediastinal mass. What could this be? Well, an infant with a posterior mediastinal, so what neoplasm are you worried about? Neuroblastoma, yeah. Do you think this is a neuroblastoma, or is there some other finding that suggests it's something else?
Maybe it's like just like normal thymus. I mean, it's.
The thymus? So this is in the posterior mediastinum. Is that what you would
Oh,
expect
sorry,
for the
sorry.
thymus?
Never mind. Sorry. No, that's the spine. Sorry. Oh. No.
Well, what do you think of the spine? Notice anything about the vertebra?
The cleft vertebrae.
Yes, so we have cleft vertebrae, right? So cleft vertebrae in association with a posterior mediastinal mass in an infant, what do we think about here? There's T1, there's T2. The mass is a large cyst in the posterior mediastinum associated with cleft vertebrae. So what is this?
Neuroenteric cyst.
That's a neuroenteric cyst. Okay? So these occur in the posterior mediastinum, again along that bronchopulmonary foregut malformation spectrum. So they can't communicate with the subarachnoid space, and these are associated with vertebral anomalies like hemivertebra, sagittal clefts, spina bifida, etc. So that's a neuroenteric cyst, right? So posterior mediastinal mass, cystic lesion, but associated with vertebral anomalies. So that's a neuroenteric cyst. Okay. Here's another posterior mediastinal cystic mass, right? What do we think of this case? Well, is there another finding?
Extension of the neuroforamen.
It does, yeah. It looks like it's extending into the neuroforamen. There's widening of the neuroforamen there. Look at the entire image. Is there another finding?
There's like a nodule in the skin.
Yeah, there are all these nodules in the skin. What does this patient have?
Neurofibromatosis.
Yeah, it's a patient with neurofibromatosis. So a patient with neurofibromatosis who has a cystic posterior mediastinal mass, what do we think this is? Of course, you might get cystic neurofibromas, but
Lateral thoracic meningeal.
that's a lateral thoracic meningocele. Yeah. So herniation of the meninges, sometimes these patients have scoliosis and it can occur at the apex of the curve. Okay, so this is herniation of the meninges in patients with neurofibromatosis. That is a lateral thoracic meningocele. It communicates with the CSF. If you do a myelogram there, the contrast will get into that. So that is a lateral thoracic meningocele. Right? The history here is chest pain radiating to the back. I'll show you the frontal view, and let's be fair here. Let's show you the prior study from 4 years ago. Is there anything different about the current study versus the prior study? Is there anything that looks different?
Yes.
What looks different?
Okay, it looks like we have a left posterior peri-spinal mass.
Okay, so this line here is what?
That's just the aorta.
Yeah, it's the aorta, and then there's this extra bulge here, right? So here's the aorta, and now there's this new bulge on the left side, right? Anything on the right side?
Yes,
Okay, what is this guy?
that's our, that's our, like a bulge of our spine.
What am I pointing to?
Oh,
Look at the old film. What am I pointing to? That's the right heart board. So there's this extra bulge here, right?
oh, I see.
So we have these bilateral, so there's bulging of what lines?
Paravertebral lines.
The paravertebral lines, right, bilaterally. So that points to what compartment? Posterior mediastinum. What could this be?
Like peri-spinal abscess.
So somebody with back pain, right? So see these bulging of the paravertebral lines, which is new compared to the study 4 years prior. And indeed, that is a paraspinal abscess associated with discitis and osteomyelitis there in the vertebral body. So paraspinal abscess can also give you a posterior mediastinal mass. So there's the destroyed vertebral body, there's our paraspinal abscess. Okay? So can result from hematogenous spread of tuberculosis with discitis and osteomyelitis. Some patients might have other findings of tuberculosis in these cases. Okay? Gibbous deformity, kyphosis, you might see that. Here's a case where there's collapse of the vertebral body, one vertebral body into the other one with destruction, loss of the intervertebral disc space. So this was also a patient with a paraspinal abscess. You can see here on the CT scan. Then on MRI, nice way also to demonstrate that was the destruction of the end plates and the paraspinal masses from the paraspinal abscess. This patient has this vague retrocardiac mass there on the right side. Here is the CT. So there's our mass. What can we say about this case? Well, is there one or more than one paravertebral mass? There's more than one. There's one here, one up there, there's one over there. So do we think this is neurofibromatosis, or do we think it's something else?
Something else.
What's the something else?
It's
Why do you say that?
Small.
Yeah, so you have a small calcified spleen. So what's this patient's underlying disease?
Sickle cell.
This is a patient with sickle cell disease. Also, the bones look abnormal. So if you have posterior mediastinal mass with abnormal appearing bones, think about extramedullary hematopoiesis. This is a patient with sickle cell, which is why there's a big heart, a small pericardial effusion, but the autosplenectomy really gives it away there, the small calcified spleen. Okay? So extramedullary hematopoiesis associated with severe hemolytic anemias, thalassemia, spherocytosis, or sickle cell disease. So we will see these paravertebral masses. So bilateral paravertebral masses, you can think about extramedullary hematopoiesis, especially if the bones look abnormal. So if the bones look expanded, if the bone marrow is expanded there, and you have masses in the paravertebral regions, you want to think about extramedullary hematopoiesis. This is that case that we saw a little bit earlier today, this posterior mediastinal cystic lesion and a 55-year-old woman. So dark on T1, bright on T2, bright on T2, no enhancement. Given that history, there is a particular lesion that this could be, and what is that?
Cystic Hattori.
A cyst of Hattori, and what kind of tissue lines the cyst?
I think it's like the same as the fallopian tube.
Malarian tissue, right, also called Malarian cyst. So posterior mediastinal paravertebral Malarian cyst. So these can arise in the paravertebral regions, middle-aged women, estrogen and progesterone receptors, and it can be associated with some of these other factors there. Solitary cyst between T3 and T8. So if we have a posterior mediastinal cyst, middle-aged woman, you can think of this, a Malarian cyst, or cyst of Hattori. Okay? This is a differential for types of mediastinal cysts. I've listed them out and given, so that's also in your handout. Okay? This is something that you come across pretty regularly on chest radiographs. What do we think that is? That's a Bachelek hernia, right? So it's a characteristic appearance, kind of this round mass right over the diaphragm, fatty attenuation there because it's fat that's herniating through this diaphragmatic defect. Okay, so that's just a Bachelek hernia. If I tell you this is patient has a history of liver disease, and we see this quite a lot here too. There's our retrocardiac mass. What does this turn out to be?
Varices.
These are varices, right? So these also can give you mediastinal masses, these paraesophageal varices in patients with cirrhosis. If we see something like that, then we know what it is, okay? This, of course, always on your differential for big mediastinal masses. If you can't separate it from the aorta, of course, you have to consider aneurysm, yes. So always consider that regardless of the mediastinal compartment. We always want to think about aneurysms. Let's talk about now more diffuse mediastinal abnormalities. So here there is widening of the mediastinum, but it's very smooth. You see, there's no lumpy bumpiness, no lumps, very smooth widening of the mediastinum. What can do that?
Pulmonary edema.
Pulmonary edema gives you vascular engorgement, right? It doesn't give you smooth widening of the mediastinum.
Lipomatosis.
So mediastinal lipomatosis can give you smooth widening of the mediastinum, right? A very easy diagnosis with CT. So this is associated with Cushing's, obesity, steroid use. That gives you very smooth widening of the mediastinum. So we can't see that. Okay, mediastinal lipomatosis. That's pretty easy diagnosis. This patient has chest pain 3 weeks after CABG on the lateral view. Do we notice anything? No, I mean, you know, what is this back here? It's, yeah, there's a big pleural effusion, but is anything else? We have these clips. If you look in the anterior mediastinum, does anything bother you there?
Some gas there.
Yeah, there's lucencies, right? So it looks like it might be gas. What would you be concerned about?
Abscess.
Abscess, right? You can have gas postoperatively, but 3 weeks is a little bit too long, right? So this is a mediastinal abscess. You have gas there with fluid in the anterior mediastinum, right? So here's another patient with evidence of mediastinitis, right? So we have these bubbles in the mediastinum, loss of fat planes. So of course, mediastinitis can be caused by, you know, post-op, right? If the patient's had surgery, sometimes you can have microorganisms that disseminate there just hematogenously. But there is another important cause of mediastinitis that you also need to consider, Boerhaave's, right? That can be associated with left effusion, perforation of the esophagus. What's another cause of mediastinitis that you should also think about? How does infection get to the mediastinum? Oh, if you're sitting in the neurosection, what might you think about?
Let's get this last one.
Retropharyngeal abscesses. So these abscesses in the neck can also extend down to the mediastinum, right? So it's important if you're imaging these patients, that's why your routine CT scans of the neck will go down to the tracheal bifurcation, right? You also want to evaluate the mediastinum. So retropharyngeal abscesses, these can also extend down to the mediastinum, okay? So you want to make sure about that. So we've talked about mediastinitis, mediastinal abscesses, we've discussed that. You're reading an ICU x-ray, here it is, and here's the most recent prior, 6 hours before. What's the difference between the film you're looking at versus the film that's 6 hours ago? What looks different?
Lucency of the right lung.
Okay,
And what else?
The mediastinal widening.
yes, so notice all of this mediastinal widening, and what's a clue that it's often real is that you can see the aortic knob and you really can't see it. It's obscured now. Okay? So you have this abrupt widening of the mediastinum in a patient who's in the unit. What do you think about?
Hemorrhage,
From what?
did like a recent procedure.
So you're going to call and you're going to ask, what are you going to ask? You're going to call the unit and you're going to ask what question?
Have they had any recent like trauma or procedures?
Was there an attempted line placement? Okay. And this patient did have an attempted line placement, and this is what happened 6 hours later. Right? So that's an expanding mediastinal hematoma. And on the CT, you can have the heterogeneous attenuation, the higher components, hematocrit kind of layers out a little bit more posteriorly. So this was a result of attempted line placement. They perforated the innominate artery there, brachiocephalic artery, resulted in a pseudoaneurysm and bleeding into the mediastinum. So acute widening of the mediastinum, you think about mediastinal hemorrhage. All right? So of course it could be secondary to trauma if you see it in the emergency room and after a motor vehicle accident. But if you come across acute widening of the mediastinum in an inpatient, ask about procedures, especially placements of central lines. Okay? All right, so that is our discussion of mediastinum.